Good afternoon to everybody out there in the virtual world. We're really excited this is basically a continuation of a discussion we had at the AAST annual meeting. Dr. Barry's not able to be with us just yet. She's in the operating room, so she's asked us to go ahead and get started. But we're going to touch on achieving health equity by eliminating healthcare disparities, a call to develop, integrate, and measure health equity standards within acute care surgery. We have a pretty fantastic panel assembled. We're going to try to keep it to about 10 minutes each, so we have time for discussion at the end. So this is important for so many reasons, but one is that Vizient has fairly recently identified equity as one of the additional domains of quality. The Joint Commission, similarly, is now mandating sound like George W. Bush, strategies for reducing health disparities, screening patients for social determinants of health, and developing an action plan to address identified health disparities within patient populations. CMS, this will be talked about in a little bit more detail by Dr. Cow later, but payment will actually be tied to mandatory reporting of social determinants of health. Voluntary reporting starts this year, mandatory next year, and payment determination will be in place by 2026. So important for financial reasons as well. The American College of Surgeons is further tying the concept of health equity to ACS verification for both trauma and EGS programs. Further motivation for us and our institutions to explore and track health equity measures within our systems. Again, as I mentioned, we have a really great panel of folks. We're going to try to leave time at the end. I won't read you what they're going to talk about because they're going to do it a lot better than I could do it. And I'm going to go ahead and hand it over to Dr. Zachrison from the University of Chicago.
Thank you, Dr. Bruns. I'm going to get my talk up here. And it is indeed a true honor to be here with everyone today. And I do have some funding from federal agencies to disclose. So I think, it's important that we talk about health equity standards, but it's also hard to do that without a historic context. So I would like to talk about historic policies that have been rooted in structural racism and why we're having this conversation today. And really to understand that, I would invite you all to read Zinzi Bailey's Lancet series, and she's a social epidemiologist from the University of Miami, where she does directly link structural racism with health inequities. And she reminds us and posits that the United States is indeed a slaveholding republic and colonial settler nation. And our economy was actually based on the stolen land of indigenous peoples, as we know, and also slave labor. And that racial exploitation that was our early economy gave rise to racial capitalism as we know it today. What was interesting at that time is there was this philosophical wave on both sides of the Atlantic of the universal rights of man, but then that became hard to talk about the universal rights of man while putting human beings in chains and using them as slaves. So then we came up with the social construct of race. And we said, well, a slave is randomly 3/5 of a man, so therefore they are not entitled to the universal rights. These policies persist till today, and this is why we see the racial wealth gap, which is really what we're talking about when we're talking about health inequities. And the racial wealth gap tends to be a lot greater than what white people in general think it is. So it's $100 for every white family wealth versus $5 for every Black family's wealth. And that's generated through two mechanisms: post-secondary education, which, if you rely on public education, is predicated on property tax, which is underfunded in poor neighborhoods, and home ownership has been discriminatory as well. Claudia Golden won the Nobel Prize in Economics, the equivalent thereof, this year, and she's done a lot of work on the gender wealth gap as well, and has been demonstrating that this has been increasing. So what does the racial wealth gap do? This leads to direct harm, and that harm is manifest in excess mortality rates, which is absolutely horrific if you think about it. And this is really nicely elucidated by Benjamins and DeMeo in a longitudinal study of all-cause mortality rates across 30 cities, where there's 74,000 excess Black deaths a year in the United States. There are many examples of structural racism in the United States. Something I actually didn't even know about is the Second Amendment to the Constitution. Had nothing to do with guns, but it had more to do with militias. And to woo Virginia, the state of Virginia, into the Union, they said, okay, we'll join, but if our slaves revolt, we want an armed militia to crush them. And we said, okay to that. Another example is also abortion access, where with the Dobbs decision, the overturning of Roe versus Wade, we already see increased mortality and morbidity, specifically of women of color. So again, Bailey and her colleagues have talked about structural racism, and they've honed in on certain policies that are the root cause of the health inequities we see today. And it's important to discuss these. What's interesting is we're seeing increased research in redlining and the direct link towards firearm violence, and even with modern day firearm injuries that we're seeing. And there's a specific interest in surgeons and trauma surgeons looking at this and making the connection between structural racism and firearm violence. And again, keep in mind, this was a government policy. This wasn't just banks doing, the corporate bank thing. This was a government policy that excluded Black families and Latino families of getting mortgages in desirable neighborhoods. And you can see the overlap with firearm violence right now. John Rich has an interesting theoretical model of how that injury leads to re-injury, especially with firearm violence. And at the center of that is a disrupted sense of safety. And that will inevitably also lead to prison and incarceration. I don't need to remind anyone on this call that the United States is the most incarcerated country in the world. It's the most unfree country in the world. And it's also highly incarcerated on a racial level. So 1 in 3 Black men will be incarcerated in their lifetime. And this also has a lot to do with the state-sanctioned violence that we see in this country as well, where 1 in 1,000 Black men and boys will actually be killed over their life course by police in the United States. So it's a huge public health issue. So if we're going to think about unequal healthcare, it's important to read the book Medical Apartheid. I would invite you to do this, do that, and understand how, for example, so many structures and mechanisms in our healthcare system that we have today are remnants and manifestations of structural racism, especially employer-sponsored insurance, because that was designed that way to exclude people of color because they would have the lowest paying jobs if they were employed at all. We know bias is prevalent in our healthcare systems. It's prevalent in surgeons even as well. And bias can lead to morbidity, but it can also lead to increased mortality, and not just in the United States, but also in Canada as well, where research has shown that male surgeons do have a higher mortality rate, and we still don't quite know why that is. So there's action needed to eliminate these policies. And I think when I'm doing research, our group and our teams together think about, am I doing something that's helping my patient cope with an inequity, or am I trying to eliminate that inequity in the first place? So other questions I have become, am I addressing a true knowledge gap, or is this a policy gap? And I like the work done by Himmelstein and Wohlhandler with the first article at the top, which talks about patient dumping. And really it was like one of the preeminent research studies that paved the way to the EMTALA Act in 1986. And you need to understand, who is your audience? Is it going to be my peers, my colleagues? Do they have access to my literature? Or is it going to be the audience at large? And maybe I need to convert my peer-reviewed research into an op-ed or something. How am I conducting my research? Maybe I don't like the variables I'm measuring. I don't think they're tight enough. Maybe I want to be working in a multidisciplinary group with epidemiologists the way I work with biostatisticians. And how do you do this as a collective? I'd like to highlight some work of one of our superstar surgical residents, Annie Polcari, who said, you know what, I don't want to use the social vulnerability index to predict firearm violence because that's designed for hurricanes and natural disasters. So she, together with Drew Benjamin, created their own firearm violence vulnerability index, which is a composite score that relies on machine learning is very predictive as well. Something they did that was also very interesting is they said, we're not going to plug race in as a predictive variable because we know, as we talked about earlier, that race is a social construct and it completely negates the historic complexities and contexts within which people reside that make them affected by community violence. I personally have really enjoyed actually working with attorneys and legal aid attorneys, and we're about a year into our recovery legal care medical legal partnership at our trauma center, where we have legal aid attorneys going to the bedsides of our patients have been shot. And we're looking at the justice gap. Same thing with crime victim compensation. We're saying, where is the government failing in supporting our patients, certainly after injury, but in a way so that we can support our families to prevent the injury from happening in the first place. So we are considering legal action once we identify these justice gaps. Mary Bassett and Sandra Galea really spoke to this extremely well when they talked about structural reparations as a public health priority, because if we truly, as a community of trauma surgeons, are going to address the racial wealth gap, we need to do that from the ground up. So they talk about reparations in terms of expanding the extremely limited resources that are available to Black Americans. We need to think about how we reduce the stress or the allostatic load felt by many Black Americans, and also level the wealth playing field. What's very interesting to me is we actually already are using structural reparations and have across the United States, but we're using it just north of Chicago for families who have been redlined. And it's going to be interesting to see and measure what the public health implications of those reparations have been. Something that truly fascinates me about this country is the ability of so many human beings in this country over decades to centuries to speak truth to power. And that's especially during times of national reckoning. And I think that's very, very important if you're really going to get to the core part of protecting public health and the public good and the common good of all citizens here. So we need to keep in mind for the historic policies, we need to think about the racial wealth gap and how we're going to truly speak about that and address it. And also what actions we're going to use to eliminate those policies. And I would posit the idea of engaging in structural reparations specifically to address that racial wealth gap. With that said, I'd like to say thank you very much for joining us today. Thank you.
Thanks. I'm going to continue the conversation. My name is Marta McCrum. I'm an acute care surgeon at the University of Utah and health services researcher. And I'll pull up my slides. Oops, now you can see my calendar. Try this again. Okay. So I'm going to be talking about targets and strategies for measuring equity and access to acute care surgery. Inequities in access and quality of care for trauma and acute care surgery have been well documented, and some of the largest gaps have been with respect to geographic or spatial access to care. And this is because of the time-sensitive nature of our field. Unlike for many conditions where patients might select hospitals due to insurance affiliation or prior relationships, geography for us plays a substantial role in this choice of hospital. And health system structure becomes really important here. Renee Shaw is an emergency medicine physician and health services researcher at UCSF. And she wrote that structural barriers are among the most pervasive and under-researched factors responsible for the observed disparities in the emergency medicine system. And so in this discussion, I'm going to focus on three major health system targets for measuring equity in acute care surgery. First, pre-hospital care, secondly, inter-hospital transfers, and finally, regional health systems. We all know that pre-hospital care is important. It's where the start of resuscitation takes place and key interventions, but it's also involved in the selection of an initial hospital for patients, which impacts the availability of resources that they receive when they get to that hospital, the quality of care that they receive, and financial impact downstream on the patient. And this decision of hospital choice and selection is subject to structural barriers that once again have downstream effects on disparities that we observe. This paper is from Dr. Berry's group. They examined EMS records for the Northeast region of the United States and found that of 94,000 critically injured patients, 44% were transported to a non-trauma center. And then when comparing men and women, they found that critically injured women were 19% less likely to be appropriately triaged to a trauma center. And a reminder that these are critically injured, so not just all injured patients, but patients who should be, are injured enough or more severely and should be triaged to a trauma center. This paper examined EMS transport destination of Medicare patients and found that even within zip codes, EMS transported white and Black patients to different hospitals. And even more surprisingly, for serious injury or trauma, where again, we would expect geography to direct the patient to the nearest trauma center, the discordance in destination for Black and white patients approached 9%. So to address these inequities, it's important to understand the drivers. Dr. Berry and her team received a major grant this year to start this work and identify how sociospatial disparities in pre-hospital care for trauma patients affects their outcomes. Moving on to interhospital transfers. This is a second target, and it's important because interhospital transfer is a key mechanism through which patients can gain access to care if they initially present to a hospital that doesn't have the resources that they need. And it's particularly important for rural, minoritized, and socioeconomically vulnerable communities because these communities have been found to have lower spatial access to emergency surgical care, to trauma care, or to hospitals where they can be, where they can receive advanced resources. And there are well-documented disparities in who gets transferred. Differences have been noticed in secondary triage for severely injured trauma patients by insurance. Our team had identified substantial racial and ethnic disparities in interhospital transfer for complex or severely ill EGS patients who present to community hospitals. And finally, during COVID, or during the height of COVID, bed and hospital system capacity constraints prevented transfer of rural surgical patients needing ICU care with substantial impact on outcomes. And the third box here is an NPR article about a young patient who unfortunately died because there wasn't an appropriate bed available for her to be transferred to. Regional transfer systems have been proposed and adopted as a solution to this during COVID. Certain states, Washington State is an example where there was a central state transfer agency that was managing all the transfer requests. This article by Margaret Greenwood Erickson and her colleagues offers a few lessons that they learned from their experience in New Mexico. And these solutions are designed to support equity in hospital transfers. There are a number of points that they raise, but some of the three of the most important ones are to adequately fund and support state-level transfer centers when a state is at or near capacity to use standardized protocols to allocate transfers. And finally, to ensure representation from Indigenous, rural, small town, and high-share minority serving hospitals and groups that are leading healthcare system planning so that these groups have a seat at the table. And finally, I wanted to talk about regional health systems. And in order to really address population health disparities, we need to adopt a systems-based approach. And so I have three suggestions on how to make this happen. First is to define geographic regions based on real-world data in acute care surgery patients. Often we think when we're thinking about health regions or the regions that our hospitals are responsible for, we think of either political or state borders or county borders or other predefined regions like those of the Dartmouth Health Atlas or Dartmouth referral regions. And that data that's used as 30-year-old data that was not based on surgical care or emergency care. And so when I say using real world data, this is one example from our team. This is most of this work is done by Jasmine Hahn, who's an outstanding PhD candidate working with us. And here we've mapped all interhospital transfers in New York State in 2019. We used community detection and modularity optimization to identify these real regions. And so the border outlines here reflect what the actual regions are that tertiary centers are serving in their connected hospitals. This data can be used for development of regional collaboratives, regional transfer systems, and to measure population outcomes for given health regions that reflect real world. So moving on to suggestion 2 would be to assess population outcomes for regions and not just individual hospitals. First off, trauma registries fail to capture large proportions of trauma patients. So using TQIP will not necessarily capture all the outcomes from the patients or the trauma patients that we care about. And then population reporting allows us to examine for equity among disparity populations. And this can be tricky. This paper recently published in Health Affairs offers a unique solution using equity weighting. There are problems using overall measurements of quality, like you might see for certain process measures in your hospitals. That effectively presents only dominant populations. If you are in a region where, like I am, that is predominantly white or predominantly urban, your average, overall hospital metric on a given quality metric will effectively be dominated by that group. Using stratified data is another option, but there are problems with that, as one underrepresented group may be at odds with another underrepresented group. And the classic example of that is rural populations in the United States are dominated by white Americans, and certain minority populations are predominantly located in metropolitan areas. And so if you are designing interventions to improve rural America, are you then taking away or failing to improve care for minority populations? So stratified data can be problematic in that way. Similarly, assessing just the disparity itself has problems associated with it too. And so this group looked at using equity weighting, which uses an optimization method to assign weights to each group and then allows alignment with quality improvement incentive programs in a way where no one group loses. And so if you look at the graph on the left, this is what their population actually looks like. This is for colorectal cancer screening and Medicare patients. You can see that my white metropolitan group is the dominant population, followed by white rural, and then black metropolitan and black rural. And when they applied their weighting initiative, if you go all the way over to the right, you can see a lot more equity of each of these populations. It also allows for incorporation of intersectionality in your equity measurements. And then that brings me to point 3, which is regional incentives for population outcomes. And once again, most of our pay for performance or incentive initiatives are based off of the population that is treated within the walls of our hospital. But again, if we're going to try and improve population outcomes, we need to think outside of the walls of our hospital and the population, the total population health. And so we need to adopt incentive that encourages shared responsibility for residents of our regions, and encourages cooperation amongst hospitals and health systems to improve quality of care across the spectrum, all the way from pre-hospital or injury prevention, pre-hospital care, and then through hospitalization to discharge. And I'll stop there. Once again, I'm grateful to be part of this group and look forward to questions and discussion.
Awesome. I think that brings it over to me. And I'm going to kind of shift focus here a little bit.
Thank you, Dr. Bruns. I apologize for being late. I was called to the OR unexpectedly, but I want to introduce you. You're Dr. Braden Bruns at UT Southwestern, going to give us a talk on the workforce and leadership as we advance health equity across our field.
Yes, ma'am. Can you see that okay?
Yes.
Okay, great. So yeah, I'm going to kind of shift focus here and talk, maybe about us as an acute care surgery community. What is the current state of diversity and what are the opportunities that we may have? And again, I didn't mention this at the beginning, but none of us, I think, are positing to have all the answers. And maybe at the end, we can talk a little bit with you all about what you think some strategies are we can take. This is a snapshot of the demographics of acute care surgery. It comes out of some work we did around 2018. We surveyed East membership through the East for All committee, just looking at demographics of the members. And you can see that most of the respondents were white, 58% were male. almost 90% identified as heterosexual, and 53% were Christian. This paper, which came out in 2020, sought to explore more the gender distribution in some of our surgical societies and surgical critical care as a whole. So you can see that despite comprising almost half of medical school graduates at 47%, in 2018, women made up only 22% of boarded general surgeons and 28% of surgical intensivists. So this paper was a retrospective collection of membership, leadership, and other data. This is from the 2016 to 2018 annual meetings of some of our surgical societies. If you look at East, which is the yellow bar, compared to membership, you can see that representation in executive leadership and the board of directors fell behind. Committee membership closely mirrored actual membership. For Western trauma, which you can see in the red, women held a higher percentage of committee leadership positions and committee membership compared to overall membership. Though the AAST had the lowest percentage of female members, only 13% of the membership were females, you can see there's robust representation in both executive leadership and committee leadership. This is one from 2021. This sought to evaluate the trends among underrepresented racial and ethnic groups in academic surgery, specifically looking at some leadership levels. Overall representation of non-white male surgical faculty has increased from 2013 to 2019 across all ranks except for instructor. That said, most of this growth is in individuals of Asian descent. Non-white male faculty representation remains disproportionately low amongst full professors and chairs when compared with instructors, assistant, and associate professors. When white faculty maintain most leadership positions with 77.7% of full professors in 2019 and 77.4% of chair positions in 2019. The greatest magnitude of underrepresentation along this pipeline has been Black surgeons. They're represented at 2.7% of full professors in 2019. Hispanic Latinx, only 4.4% of full professors. For chairs, the numbers are even lower. It's 5.3% for Hispanic Latinx and 3.4% for Black surgeons. So we looked at faculty. Let's move a little bit earlier in the pipeline. Let's look at residents and what is the resident experience. This paper looked at resident attrition in certain surgical subspecialties. This is published this year, and it looks at a cohort from 2001 to 2018. Demographic trends are analyzed over the 18-year period. These were some of the big take-homes. The mean percent of females was 40%, and that actually increased over the time of the study. Sex disparity in residency was greatest in orthopedic surgery. Residents who were underrepresented in medicine made up 14.9% of all trainees, and that number actually decreased over time. The overall attrition rate was about 7%, unintended 2.3%. Females had higher relative risk of attrition than males, and underrepresented in medicine residents were at significantly higher relative risk for attrition. And unfortunately, Black African American residents were at the highest disproportionate risk. Here, we break it down by surgical subspecialty, and you can see that orthopedic surgery had the highest attrition and unintended attrition for Black and African American residents. This is a survey of general surgery residents. This was done after the 2019 ABSITE exam. You'll remember from our East for All survey, 87% of respondents identified as heterosexual. LGBTQ plus general surgery residents were more likely to experience sexual harassment, bullying, and most of that bullying was actually done at the hands of the attending surgeon. They actually considered leaving the program in higher numbers, and they considered suicide in higher numbers than the straight peers. All right, so now that's kind of possibly the state of what we're dealing with and what we're facing. Here are some ideas from people who are much smarter than me. Dr. Capers is our DEI chair at the University of Texas Southwestern, and this is New England Journal of Medicine piece that he wrote, and just some areas where he outlines as potential opportunities for improvement. You can make diversifying an actual deliverable for senior leaders in an organization. Search committees should declare diversity as a clear priority. When looking at candidates' merit, can include the potential to advocate for health equity as one of the things that you are evaluating. I think this fourth one is important, very important. Implicit bias training for interviewers. This is something we do at UT Southwestern. All interviewers are trained in implicit bias training. Form cooperative agreements with previous stage institutions. For a medical institution, a medical school, maybe you can partner with an undergraduate institution and focus on URIM individuals to try to get them interested in medicine. Maybe it's focusing on high schools. There are various ways to do this. Whenever we're posting our faculty jobs, we talk about this fairly frequently, but go to varied forums. Don't perhaps just post your job at East and AAST and hope to get the most diverse field of candidates that you can find. When you're doing these big searches, you search firms that actually have a history of success in this area, and then medical school community outreach initiatives to try to reach individuals who otherwise maybe are not being reached. This is more work from Dr. Berry and specifically the AAST. This is already out there. A lot of these are the same things that Dr. Capers mentions in his piece in the New England Journal of Medicine, which I would suggest you look at. But I think what comes out to me is really looking at this as an actual metric, like anything else that we evaluate in a department. Support those who are actually doing the work. They might need time, they might need finances. And then actually commit the funding to these initiatives and be intentional. That's all I have, in considering where to put some of our employment ads. These are some of the organizations that we may go ahead and consider in addition to ours. I will stop sharing, and then we're happy to take more questions at the end. Thanks.
Thank you, Dr. Bruns. And finally, last but certainly not least, Dr. Lillian Cow, professor of surgery at McGovern at UT Health Houston, is really going to talk to us about identifying those health equity metrics that we should be capturing as we, adhere to this goal of how do we integrate and measure health equity standards within our field. Dr. Cow.
Great, thank you. And thanks to everyone for joining us to talk about these important topics. So I don't have any relevant financial disclosures, but I will say I am fairly involved in the quality verification program at the American College of Surgeons and in DEI efforts for the Committee on Trauma. But what I'm saying is not necessarily the point of view of the ACS. That being said, I did want to briefly touch on sort of overall, how do we incorporate equity into our verification program? So for example, the American College of Surgeons has over 100 years of experience with verifying programs. Obviously, ACS verifies trauma programs, now EGS programs, and also has an overarching quality verification program. And there's really 4 pillars to their continuous quality improvement. First and foremost is to set standards to guide practice. We're all very familiar with the charcoal book that details all of the standards. We need to build infrastructure and then collect data to measure performance. And ultimately, the final pillar is to verify that performance through external peer review. And it's already been mentioned that when we talk about quality, equity is actually one of the 6 domains that the Institute of Medicine defined as the 6 domains of quality. It was previously mentioned that Vizient, which ranks hospitals based on quality of care, really only weights equity as a very small percentage. In fact, when people talk about quality, for the most part, they're talking about effectiveness and safety. And equity is really the delivery of equivalent care regardless of your race or ethnicity, gender, geography, socioeconomic status, etc. So we already know or have heard about how we might measure equity, but ultimately, if you don't measure it, it won't improve. And when I think about how we evaluate quality at hospitals, I think about the Donabedian model. We're really talking about what are the structure or all the contextual factors that contribute to quality, what processes exist there, especially around what data is obtained and how is it analyzed and used to drive improvements, and what outcomes are being measured. So when we talk about quality overall, for example, in the quality verification program for the ACS, one of the very most important components of structure is the collective commitment from the system down to the hospital level, down to the subspecialty. And ultimately, all of these levels have to be aligned in terms of their commitment to quality and safety. And I think you could substitute the word equity in order to minimize power struggles and promote teamwork, collaboration, and the common good. These are some of the structural standards that the ACS has around the quality verification program. And I think you could very easily just substitute in equity to some of these. So for example, instead of a chief surgical quality officer, perhaps you have someone who's a surgical equity officer. I already mentioned leadership commitment, and then there has to be the culture. And again, instead of around patient safety and high reliability, around diversity, equity, and inclusion. The ACS is not the only external verification organization that is committed to health equity. We already heard that CMS is starting to have requirements, and I would just emphasize that there are common themes between what the ACS proposes for quality verification and what the CMS does. And again, substituting the word equity. So equity needs to be a strategic priority, and there really has to be leadership engagement, and this is a common theme. CMS has additional health equity priorities for reducing disparities in health. And again, these speak to some of the structure that you have to have around the capacity of your healthcare organization and workforce to reduce health and healthcare disparities, and what you have in order to advance language access, health literacy, and provision of culturally tailored services, as well as in order to increase accessibility to healthcare and services. I mentioned before that processes are also equally important. When the ACS goes to verify programs in quality, they're really focused on, again, not just what data are collected and analyzed, but how is that data actually used to drive improvement, and how that data is used for credentialing, case review, peer review, and again, continuous quality improvement. We also know that in order to improve equity and to provide equitable care, we have to have standardized data collection. Perhaps we learned from Dr. McCrum that stratified data analyses may not be sufficient, but it's a start to identify equity gaps. We need to have strategies to address social determinants of health. And ultimately, again, as Don Berwick wrote in an editorial, just weighing a pig doesn't make it fatter. So you have to use your data to actually drive improvement. Just a moment on standardization of data collection. This sounds like a fairly straightforward idea, but that being said, it is not standardized how organizations collect race, ethnicity, language, for example, sexual, perhaps age and language would be the easiest to standardize, but even race and ethnicity, sexual orientation and gender identity, and the social determinants of health. Not only is this not necessarily standardized across different databases or across different organizations, but we need to be aware and conscious of having culturally sensitive and trauma-informed approaches to getting this data and having patients understand why we need this data, and also ethical and transparent use of the data. This is just a diagram demonstrating the generic 10-step process for quality improvement. You could substitute in the PDSA cycle or DMAIC cycle, but data is not useful unless you actually use it to improve care. So in this case, if you identify an inequity, how do you actually go about using that data to drive improvements? Again, ACS and CMS are not the only organizations that are incorporating equity into their verification processes. The Joint Commission also has a national patient safety goal that is part of their accreditation process, and you can see common themes. You have to assess patients' health-related social needs. You need to analyze quality and safety data to develop disparities, create an action plan, take action, and then disseminate that data. You have to inform the key stakeholders about progress to improve health equity. Lastly, we care about outcomes and how our patients are doing. Again, most of our measures are really around stratified analyses, which we already heard may not be ideal, but that being said, it may be a start. So looking at process and outcome measures stratified by subpopulation. The next step would actually be to look at specific process and outcome measures targeted at those at specific subpopulations in order, again, to inform interventions, and then ultimately targeting strategies to reduce inequities. And there may be other stratifiers that are not necessarily independent, but there's often intersectionality, as we discussed earlier, but we won't know unless we measure all of these. In the end, equity should not just be something that is included in, it should be included across all 4 pillars of quality improvement. And so we need to have standards that guide us around what is equitable care. For example, I've mentioned in previous talks that when looking at the charcoal book for standards around equity for trauma verification, the only actual standard is that you cannot transfer patients based on insurance status. There are really very few standards in the book that define how we should approach equity. You need to have infrastructure, and that has to be evaluated as part of the verification process. You have to collect the data and act on it, and ultimately, whether it's the ACS, CMS, or Joint Commission, or some other organization, there's verification of performance through external peer review. And really, this slide just says the same thing. So if anyone has any questions, I'd be happy to take them.
Excellent. Well, I just want to first just thank each and every one of our excellent, just phenomenal panelists. Really, we went from the historical policies to the current access to care, to the disparities in our workforce, and really bringing it home with, what do we do next, and how do we integrate those standards so that we're capturing that in acute care surgery. And so I think we're in the last 15 minutes. We really want to open it up for the audience and have some questions and answers and discussions about this topic. Do we have anything in the chat or in the Q&A? If not, I will throw out the first question for the group. We know what we need to do, and we've identified, the why and what's coming next. And we need to really get in front of this as an organization to help identify, integrate, and drive this process. What should we do? How do we lead in this space?
I don't have all the answers, but I'm also looking at the chat, and perhaps we can also address Dr. Davis's question about what are your top 3 challenges to achieving your goals. So one of the things that we need to do is achieve consensus around what metrics we should be using to measure whether we're providing equitable care. And we need to have harmonization across different databases, whether it's TQIP, et cetera, around how we're collecting the data around even just race, ethnicity, social determinants of health. I mean, I've filled out surveys before regarding my own demographics, and each one has a different number of categories, a different thing, you know, different level of granularity. I might be Asian, I might be Chinese, I might, you know, there's not one standard set of or rubric for collecting that data. So I think that's one challenge, is to get all the societies and organizations that are interested in doing this to be aligned and all doing the same thing, collecting the same data, using the same metrics. That's one challenge.
I would say an additional challenge to what Dr. Cow just said would be to ensure that once we do have that alignment, linking that to the pre-hospital phase of care with the hospital phase of care and the post-hospital phase of care, so that we are linked and we can really look at the entire trauma chain of survival and ensure that we are integrated across the spectrum.
I'll bring up a challenge that Brandon and I have, which is that he addressed workforce. And in order to even just educate our workforce about how to treat a diverse patient population, we live in Texas, and so we're not allowed to have mandatory training around diversity. We're not allowed to have offices of DEI or vice chairs of DEI. We're also if equity is included as a regulatory requirement by the government, we are allowed to address it. But even things like, I recently learned if we want to get a diversity supplement to a grant, that's even a challenge. So it becomes challenging to educate the workforce, which is maybe part of the solution that Brandon was talking about in certain states.
And I'll tell you one thing, like, to put a positive spin on that, if our residents at UT Southwestern have devised a structural disadvantages curriculum. So whenever we have our conference morning, we have an hour-long talk with the speaker who talks about a specific focus of, you know, a group that is structurally disadvantaged. And it is it's a breath of fresh air, really, that, you know, the residents said, this is important to us. This is something that we want to educate ourselves and you all. It's been a nice way to kind of combat that.
The next question in the chat is any recommendations on how to engage stakeholders to appreciate the importance of this in a world that is so very driven by economics and meeting budget goals?
Sharice, maybe I can take a stab at that. Hi, Justin. Thank you for the question. So I think I don't know if I should take a stab at this, but because I've thought about this for quite some time, and I think, you know, as years go by, we're not going to appeal to the moral senses of people that are kind of causing the inequities to say, please care. You know, and you're right, Justin, like, we do tend to monetize harm a lot, and that harm for us in healthcare is disease. Like, disease is what makes the money, which is why the American Medical Association has never supported a universal healthcare system, and they've lobbied actively against it. So this is why I think a lot of the research we're doing now at the University of Chicago, which is very structurally oriented, and again, our medical students, our residents are driving it, to Brandon's point, is really working with civil rights lawyers, because it's not no amount of showing them the data of harm, I think will necessarily change their perspective. I know that sounds like a very dark thing to say, and maybe, you know, is quite cynical, but on the flip side, I would invite you, Justin, and invite all of us to start teaming up with your attorneys and your lawyers in your law school, like especially Lillian and Brendan, like in Texas, that's something you want to do immediately and say like, hey, let's call it structural injustice. Let's not call it DEI, but let's keep getting the work done. But they're a powerful ally, and a lot of the people, especially within the legal aid sphere, the public benefits attorneys and the civil rights attorneys, they're on par with this, and they recognize there's public health attorneys as well that recognize the harm that these inequities are doing in the public health sphere. So they're natural allies to us. And I think that's one way of going about it, because to your point, Justin, like I said, I don't think just showing them the numbers is enough to convince people that they should change course when it's in fact direct policy, which is what I tried to show. Thank you.
I would also just add, Justin, that's a great question. I think when you tie this to what matters to some people, which is financial, so when we say that it's tied to CMS and your payment determination, we say it's tied to your AGS or trauma verification, that is very powerful. And so when you hold institutions and organizations to account, that is one method of getting people to respond. And so I think, as we approach 2024, 2025, and 2026, I think that is going to be a very powerful way to get people motivated to pay attention. Brian Meyer, how frequently do you have that conference, Dr. Bruns?
I want to say it's about once or twice a month. Wednesday mornings, it's an hour. Brian, text me. I'll put you in touch with some of our residents who've grown this, but they've presented on it too at some of the meetings. But it's a really educational opportunity for everybody involved, truthfully.
So I just want to put this question to the panel. What should be our next steps in driving and leading in the space for our field?
Perhaps bringing together the trauma-related society stakeholders to create a sort of common vision and strategic path to how we're going to achieve that vision would be a start, because I think there are a lot of different societies that are addressing or trying to tackle some of these issues, and I would expect that we would be much stronger if we aligned our efforts together.
I think that's an excellent idea and suggestion. Dr. Davis, I think that you need a consortium of appropriate organizations to begin to work across these issues. Agree 100%. And I think this is the right time to do it. This is the right time to do it. And I think we can really advance in this space and lead in this space. So I'm certainly excited that we have, all these individuals who have expertise in health equity, leading and being involved and being engaged. We have about 3 minutes left. So just want to give the panel one last opportunity for final words before we end our grand rounds.
I'll start. I think that although we tend to focus on some of the distressing facts around inequities of care, that hopefully some of the suggestions provided by the panel bring some hope to this area, because I think that we need to be solution focused, and I think that's really where we tried to aim our talks today. So hopefully people come away from this grand rounds with some sense of there are things that we can be doing to move the needle forward.
And I think one way to do that is just reaching out to those younger generations. I mean, I think workforce diversity is so important, and trying to attract those younger folks to our profession, however it may be, is just going to be really important to create an acute care surgery group of professionals that looks more like the populations they serve.
I think that trauma has really led the way in terms of health systems thinking. And so I think that, not just in clinical care, also in fields like health equity, I think that the community of trauma surgeons and acute care surgeons, because we appreciate the interconnectedness of hospitals and of patient care, and the different domains of patient care, that we can definitely be a leader in this field. And so I echo what's been said already.
Thanks, Marta, and thanks to all of my panelists as well. And just to reiterate what people have been saying, it's absolutely fundamentally true. This is completely our lane. We are the ones that see the structural violence that leads to the direct violence that leads to patients day and night coming into our trauma bay. So we deal with our patients, we deal with our families and the communities, right? And so it's not only our privilege, it's our responsibility to come together. Love the idea of a consortium, love the idea of harmonization of metrics of bringing this forward. Love the idea of tying this to ACS verification. Why can't we have 80% of our trauma patients who've been shot receive crime victim compensation, for example? These are things that we can do, we should do, and we are the ones to do it as trauma surgeons. So it's incredible to work with all of you. It's just a phenomenal group of professionals. Thank you.
Thank you. And I would have to say, I agree with what Dr. Davis just wrote in our Q&A, that we should use the success of the gun violence efforts as a roadmap to address this. So I think we have our marching orders. I think we have a group that is really passionate about this. And I think we can work together across the aisle through all of our sister organizations to identify and integrate and lead in this space. So again, I want to thank the panelists who just did a phenomenal job. Enjoyed working with each and every one of you, particularly over the last couple of years with our lunch sessions that we've put together for AAST. And so to be able to do this as a grand rounds has been wonderful.